perspective. Now we're going to look at the issue through a different lens. And I'm going to invite to the lectern Professor Jodie Dodd. And Jodie is going to be talking a little bit about this issue in terms of bringing together two key groups, academics and clinicians. Jodie is a full-time clinical academic obstetrician. She's the Medical Director of Women's and Babies Division at the Women's and Children's Hospital and a subspecialist in maternal fetal medicine. And she's currently an NHMRC Investigator Fellow at the hospital, and she also heads the Department of Obstetrics and Gynecology. And Jodie's research program is quite profound. She addresses one of the key issues of women's health, and that is to do with overweight and obesity, both in the preconception period as well as in the intrapartum period. So welcome, Jodie.
I have to confess that this is a talk that I found particularly difficult. I feel as though I've spent a week of my life thinking about what I needed to say, and I'm still not sure that I've hit the brief. So there's a few little meandering wanderings that I'm going to take you through. Hopefully they'll come together as something vaguely coherent. I thought I'd start by looking at what a clinical academic actually is. There are lots of definitions out there. I think most people would agree that it's either a doctor, a dentist, a midwife, a nurse, an allied health professional who combines clinical practice with research and or teaching. And I think if we use that definition, then all clinicians should be clinical academics. But I think we know that the reality is all clinicians are not clinical academics. So I think that bears a little bit of teasing out as well. The other, I guess the other definition or the other words that I came across was a title that doesn't fit. And I actually have to say that I feel probably 90% of my time that I'm straddling both the university system and the hospital system, and it's actually a very difficult juggling act sometimes. So this is not from the perspective of poor Jodie. This is from the perspective of, if I don't answer your email straight away, this is partly the reason why. I've put up a picture of a tug of war. I think you could equally have a tightrope walker, because it really does feel a lot of the time like there is a juggle that goes on. And I'm not claiming by any stretch of the imagination to have found or perfected that balance. So I actually have dual contracts. I have a dual contract between the university and I have a contract with health. That means that I have to navigate two very distinct systems that don't speak to each other. I have two diaries, I have two email systems that I have to maintain. I have two key performance indicators, neither of them overlap, so they're quite separate and quite distinct things that we're trying to do. Two sets of meeting, two sets of administration, and certainly one of the big headaches is two sets of bureaucracy. And I think both the hospital and the university don't necessarily move at a rate of knots. Often it's a very, very slow and very tedious process trying to navigate the systems for both. And that's without actually even thinking about family commitments and self-care and wellbeing. And I, again, do not pretend to have anywhere near the perfect balance. So these are a few things about some of the things that I think we need in the world of clinical academia. I think we actually need to really focus on clearly defined training pathways and really consciously try and increase the number of individuals who straddle both that academic and that clinical sphere, because I think having an understanding of the challenges that face both of those groups of people or both of those systems is actually key to facilitating some of the development and some of the conversations that need to happen. If I think back to my own pathway in medicine, I did my undergraduate medical degree and then undertook 6 years training to get my fellowship as a general obstetrician gynaecologist, and then made a somewhat crazy decision to run subspecialty training in maternal fetal medicine, which is a 3 to 4 year course concurrently with the PhD. That necessitated me basically coming up with my own program for how that was going to run, and I had to source my own income for how we were actually going to survive as a family. I think we've come a little way, particularly for medical staff, in terms of being able to provide more clearly defined pathways to facilitate people to undertake clinical training and postdoctoral research. Still a long way to go. I don't think we're anywhere near the mark with nursing, midwifery and allied health, and I think that's something that we really, really need to focus on as a group of clinician researchers if we're wanting to really impact that space. I think the other thing that we need to acknowledge is the need for protected academic time. I think hospitals tend to look at research as something that is nice, it's a bit of an optional extra, but clinical service delivery is what's most important, and that's what they tend to focus on. And I think as clinicians, we will always prioritise our clinical service first. We'll then prioritise teaching, and then research often falls way, way down the bottom to get done if and when we get time. So I think that's another area that we need to work on. I think one of the other things that's really important is to say that we need to have dedicated clinical appointments, and I think they're not just token appointments, they're appointments where people are really embedded within the health system, because that's where you make relationships and that's where you can actually start to have some of those really important conversations. And I think it's good that we're training people, but I think you then have to have a career path for people who have undertaken a PhD in clinical training, who can then use that maximally, rather than getting to the end of their PhD or end of their clinical training and finding that there actually isn't that academic workforce or that academic space for them to be working in. I think there needs to be a huge change in focus to research being a core responsibility and being everybody's responsibility. As I said before, I think hospitals and clinical services really need to value research as part of its core business, and until we do that, we're actually not going to improve health research as a general rule, I don't think. I think clinical staff also need to respect and understand the value of research. I think as a person who does some procedures, there's a lot of emphasis placed on being able to do needling, so to be able to do a CVS or an amniocentesis or a fetal blood transfusion. And there's recognition that that's actually a skill, but there is zero recognition that research is a skill, and that's something that you actually need to foster and develop equally as those procedural skills that we all place so much emphasis on. From my perspective, I think it's also really important that we recognise that research is science, and it's science that doesn't necessarily occur in a laboratory. I thought it was really interesting when I was trying to come up with some pictures to support my presentation about clinical research. They were all clinical researchers with a pipette and a white lab coat and in a laboratory. So I think as a society we actually need to change that focus a little bit as well, and value clinical research and really, I guess, focus on the value that that brings. I think medicine generally has got elements of science and it's got elements of art. And I think you'll find that if you ask a clinician a particular question, often there'll be a pause and it will be, well, and there will then be a consideration of a whole range of factors that need to be taken into account. So it's not just about knowing the evidence and having the evidence available, it's actually being able to apply that information to the patient that's before you, because patients, women, when they come to see us, they come with their own agenda, they come with their own risk profile and their risk tolerance, they come with their own social cultural background, and rarely do they actually fit into the nice defined box that we've designed with our randomised trials that we can directly apply the information that we might have to their particular individual situation. I think we also need to respect individuals' training and our areas of expertise. I'm teaching my 16-year-old to drive at the moment, so I feel like I'm saying a lot. Stay in your lane, no, you're veering, stay in your lane. So it's not just staying in your lane, because I think you do need to stay in your lane to a certain extent, but as Pat said, we do need to break out of our lanes and actually have those conversations. But you need to know what your lane is, and you need to know what your area of expertise is. So I feel very fortunate to be able to work with a really wonderfully diverse group of people. Deb's involved in a number of our projects and brings to the table a great psychological perspective, which I do not pretend to have understanding of or to be an expert in, but I'm very happy to defer to Deb. When we have our statistics meetings, I can ask a question of our statistician and she'll usually say, no, you can't do that, the data doesn't let you say that. But at least you can then enter into a conversation about what needs to happen and where that needs to go. So I think provide the advice that you're qualified to give. Don't be tempted to stray into somebody else's lane and provide commentary on things that, you know, maybe you're not the best person to give that advice. And I think also really value engagement and make sure that it's really good quality engagement rather than just tokenism. Yes, tick the box, we've spoken to the clinicians. I'd like to finish with a personal story. I think the meetings that we've got set up and the opportunities that we have to meet together as women and support each other in our clinical work, in our research work, is really, really important. But I'd like to raise the question of whether improving the environment and responsibility solely rests with women. The story that I'd like to tell you involved a situation where I was headhunted by an international recruitment company to apply for a quite high-level university appointment. I was very reluctant to and left it, perhaps not out of character, to the very, very last minute to submit an application. Submitted the application, got through to the interview. The interview was around a very large, intimidating board table in the boardroom. There were about 12 people on the interview panel. There was one female professor and one female who was the head of the recruitment company. Everybody else around the table were high-level clinical executives, high-level university executives, but they were all male and they were all, don't want to sound ageist, but all in their mid to late 50s, early 60s. So the stale pale male that we kind of deal with. The first question was a fairly predictable question in what are you wanting to do this role for? What do you think you could bring to this particular role? So I talked about my clinical background, I talked about my research background, talked about how it's important to bring those two things together to the table. They then spent quite a large amount of the interview time asking about what specific roles I would give up to be able to take on this new responsibility. And I think I made it very clear on a number of occasions that I wasn't intending to give up anything, and if that was their intention, then I was certainly the wrong candidate. I then heard that I had been listed as the preferred candidate, but several of the executives wanted to meet. So we then met, a smaller group, 4 pale star males, who then proceeded to ask again what aspect of my work I was going to give up to be able to take on this new role. And really spent a lot of time saying, you're very, very busy. We're not sure that you're going to be able to take it all on. How are you going to possibly manage to do all of this? Anyway, the long and the short of it is that I think we both decided that I wasn't the candidate that they were looking for. But I was talking about it with my husband and said, if I'd been a male who had brought all of these different components of my work together to the table, the conversation would have been quite different. The conversation would have been, this is a fabulous candidate. Look at all of the things that they're doing. Look at what they've achieved and their success. But because I was a woman, the conversation was around how I was going to possibly cope with all of these responsibilities. So I think we need to think collectively about how we promote women researchers, but I think we also need to challenge some of the senior executives, whether that be within health, whether it be at the university level, to actually challenge their thinking about how they value women and the terms and the pictures and the construct that we use when we're talking about women and women's achievements.